Good afternoon. I'd like to talk to you about the audit developments at the Australian Clinical Dosimetry Service, and in particular for the online adaptive radiotherapy systems using MR and cone beam based imaging. Some initial experiments for this were performed at the Ingham Institute and Liverpool Cancer Centre, and also the Calvary Mater Newcastle. The original audits were performed at the Townsville Cancer Centre and the Northern Sydney Cancer Centre Royal North Shore Hospital. I'm very grateful to the collaborators to allow us to get these audits up and running. I have no conflicts to disclose. The Australian Clinical Dosimetry Service offers dosimetry audits across Australia and New Zealand. We offer end-to-end level 3 tests for 3D CRT, IMRT and VMAT, SABRE and stereotactic radiosurgery. We have currently a total of 14 audit cases available. The new field trial, which is in development since last year, is the adaptive online cases. We are introducing 3 new cases, which I'd like to discuss with you this afternoon. The online adaptive systems in question are the Elekta Unity MR-Linac, which of course is MR-guided radiation therapy, and the Varian Ethos, which is cone beam guided radiation therapy, and is essentially just a Halcyon on steroids. The Elekta Unity for positional adjustments, the couch only moves in the supinf direction, and the MLCs then adapt for any other positional changes and any shape changes thereafter. The Varian Ethos, the position is controlled by the couch in the standard IGRT methods, and then the shape is controlled by the MLCs. The ACDS Thorax Phantom was designed for CT imaging only, and all of the components are designed with that in mind. There are no MR compatible imaging materials in the Phantom itself, unfortunately. It's a standard SIRS plastic water and lung and bone equivalent materials, none of which show up on an MR image. So to introduce some MR imaging compatibility, we replicated our IMRT insert and created a plastic water-filled replica, which could then be viewed visually on the MR T2 scans. That allows for CT fusion between the CT and MR, and using the internal structures to actually find good positioning in all directions. So we use this for case 18, our new adapt to position workflow. This is simply a case of repeating the case 7 C-series tumour volume plan with an offset phantom, which is moved 1 centimetre supinf and 1 centimetre left-right on the day of the audit. So this is planned for the Unity. We can image, plan and treat using that water-filled insert to perform the fusion and also to perform the measurements. The couch on the Unity moves in the supinf direction only, and the MLC leaves are used to adapt left, right, and any residual and post motion that is required. This was not performed in the initial audits due to lack of time. It is also not applicable to the Ethos because standard IGRT with the normal couch moves just reduces this back to the standard case 7 tumour delivery. So to produce a Phantom which had both CT and MR imaging functionality for tumour volumes in particular, we investigated the use of liquid soft plastics. This particular work from this slide was performed at our Ingham Institute at Liverpool and the Calvary Mater at Newcastle. The soft plastic Plastisol was suggested by the IROC group as a water equivalent material, which was also highly MR-Linac visible. So potentially a very good material to use in a Phantom. We found that an Australian version is also available. It has slightly different characteristics, and it actually has a better KV contrast compared to water, which is very useful when dealing with trying to produce a phantom with a tumour volume in a solid water insert and being able to actually see it on the cone beam CT. Because it is slightly denser, as you can see from the Hounsfield unit and density information on the top right hand side there, the images that you get on the cone beam are actually slightly denser, but it's more tissue equivalent than water equivalent. And then you can see from the second set of images on the left that both materials are actually visible in the MR-Linac. We performed a series of stability checks on these materials, and over a period of 55 days there was no apparent change in Hounsfield units or MR signal for non-irradiated or irradiated materials given 1000 Gray over that period. We also had a look at the apparent chemical shift, and for the small volume in the Unity T1 scan, there was a very minor, if at all, chemical shift applied. So case 19 then used the plastosols to produce a adapt to image target case, where we recontour the modified tumour volume from the imaging. When the phantom is sent for CT, we provide the centre with a straight cylindrical volume. It's a US plastisol gel involved in surrounded by perspex, and you can see the perspex clearly on the CT imaging to highlight the GTV and then create a PTV from that. Case 19 measurement point is then placed in that volume. The best way to visualize this is on the left hand side there on the bottom. You can see the case 19 point in the center of that volume. On the right hand side, on the day of the audit, we provide a second insert for the guys to image, and they then fuse the images to that. The central large cylinder is the same as that provided originally, with some extensions, SUP and INF, to allow them to contour for the adaptive case. So we then tested the Unity in its adapt to shape workflow. Because there's so little information, just that one point, we placed a Superflex bolus sheet on the surface to give increased signal so that the scan would actually be produced, and also to outline the anterior surface of the phantom. For planning and treatment, the Superflex was removed. Once the images were fused, then the planning could continue. The final shape was used for imaging only, and the plan was given the density of the surrounding solid water for the actual plans. We used a SIRS solid plastic water insert for the microdiamond measurement. You can see that there on the bottom right. So to perform this same case with the ethos, the imaging was much simpler. We did not need the Superflex because all of the internal structures were visible on the cone beam CT. For planning and treatment, same applies. The cylindrical volume, the plan for the cylindrical volume was adapted to meet the new volume for the new tumour, and then we replaced that insert with the SIRS plastic water insert and performed the microdiamond measurement. Producing the case 19 physical tumours was actually quite time consuming and used up a lot of resources quite quickly. So we wanted to find a way to fool the system so that we could use an adaptive virtual target approach. This would allow us to look at various shapes without actually having to make them. So the first thing that we have tried is actually to take the case 7 C-series tumour volume and morph it a little. We've moved it away in all directions from the exclusion volume and used that as our original target volume. We then, on the day after the image fusion, we then simply rename the PTVs, and which allows us to then actually use the case 7 PTV itself as the final adaptive volume. We found that the Unity Adapt to Shape workflow, it worked quite well. Again, we used the PEEK plastic water-filled insert for our fusion and imaging, and we were able to then perform the final plan adaptation quite easily. So case 20 on the Ethos is much simpler. We use the standard Phantom with no additional inserts required because it is simply cone beam IMRT as we would do for any other case. The reference plan on the original PTV, there's a very nice image there which actually has the case 7 PTV outlined there in the red, and you can see it's pulled out slightly away from all of that. And then on the right, you can see that the adaptive PTV has pulled in to actually cover the original case 7 PTV. So having introduced and measured case 20 and also case 7 on the same day, we were able to then compare the standard planning of an IMRT plan versus the full adaptive planning of the IMRT plan for both systems, and we found that the average local dose differences were coming out at less than 1% for each of the systems. So recapping on our results, we found a locally manufactured tissue equivalent soft plastic which provided suitable contrast against SIRS plastic water for both the Elekta Unity T1 MR images and the Varian Ethos cone beam images. Both the Unity and the Ethos could also incorporate the use of virtual targets into their adaptive workflows. The preliminary results indicate that on both systems, the dose delivered to the concave target from a standard IMRT plan agrees with that delivered using an adaptive approach to within 1%. And I'm happy to report that our first Australian audits for online adaptive radiotherapy systems were successfully completed at the Townsville Cancer Centre and the Northern Sydney Cancer Centre at Royal North Shore Hospital. We used virtual targets and a common phantom for the MR and the CT-based imaging. We look forward to performing more. So thank you very much for your time, and please ask any questions of us at the Australian Clinical Dosimetry Service. Thank you.